Let's look at how capillary exchange works. You have three types of blood vessels. There are arteries. These are what carry blood away from the heart. So arteries are taking blood to your capillaries. You have the capillary, where exchange occurs. And then you have the vein that takes blood back to the heart. So it takes it away from the capillary. So in this picture, we have an arteriole. This is bringing blood from the heart into the capillary. This middle part represents the capillary, where exchange is occurring. Blood flows through the capillary, it exchanges with the cells, then it goes to the venule, which takes it back to the heart. We have two forces that cause exchange in the capillary. One of those forces is hydrostatic pressure. Here's a demonstration of hydrostatic pressure. Let's use this water bottle to understand hydrostatic pressure. Water pushes against the walls of its container. So if I poke a hole in this water bottle, the water squirts out. Notice the water's not just dripping out, it's actually squirting. There's force pushing it out. As the level of water gets lower, then there's less force pushing the water out, and it won't squirt out as forcefully. So you can see that as the level of water goes down, the stream of water is not going out as far. The other force that we are dealing with is colloid osmotic pressure. Here's a demonstration of colloid osmotic pressure. You learned about colloid osmotic pressure in Chapter 18. Remember how plasma proteins hold water in the blood? Here are the water molecules. Here is the plasma protein. If you have plasma protein, it attracts water. Colloid osmotic pressure is the plasma protein pulling water into the blood. So now you know what these pressures are. Hydrostatic pressure pushes out. Colloid osmotic pressure is your plasma proteins pulling in. These two forces work against each other. So the third force that we're going to have is net filtration pressure. This is the sum of the two opposing forces. So now let's look at what's actually going on in a capillary. As blood enters the capillary at the arterial end, you have a hydrostatic pressure of 35. So that means there's a force of 35 pushing fluid out of the blood. You also have plasma protein in there, and that plasma protein is pulling in. It is pulling in with a force of 21. So you have 35 pushing out, 21 pulling in. Think of it like a tug of war. These are two teams fighting over what's going to happen to the fluid in the blood. Well, in this case, The pushing out wins. It's the greater force. It wins by 14. So you have a net filtration pressure of 14. This means that in the arterial end of the capillary, filtration occurs. Since hydrostatic pressure pushing out is greater than colloid osmotic pressure pulling in, you have a net movement of fluid along with the nutrients and oxygen and hormones and whatever else it contains moving out of the capillary and into the tissues. This is how you deliver your nutrients and oxygen. Now we're ready to move to the venous end of the capillary. Remember with the water bottle, as the level of water goes down, there's less force pushing out. Since we had water leaving the capillary at the arterial end, there is now less water right here. Since there's less water, there's less force. So our hydrostatic pressure is now down to 16. We didn't lose any proteins though. Nothing changed with those. Proteins are too big to fit out of the capillary. So our colloid osmotic pressure is still 21. Now when we go to get our net filtration pressure, when we add these up, the colloid osmotic pulling in is the greater force. So now our net filtration pressure is inward. And it wins, colloid osmotic wins by 5. So now we have a net filtration pressure of 5 going in. So at the venous end of the capillary, reabsorption occurs. This means we have a movement from the tissue into the capillary. This is how you pick up the waste from your cells. Something you may notice if you compare those two net filtration pressures. At the arterial end, we had 14 out. At the venous end, we have 5 in. This doesn't quite add up. There's 9 missing. So you do have more fluid go out of the capillary than returns to the capillary. This means that every time blood flows through a capillary, you leave fluid behind. This would cause edema. You would have fluid building up in your tissues. But you have a solution to this. Remember, physiology is all about problems and solutions. Your solution to this problem is your lymphatic system. You have lymphatic capillaries that intertwine with your blood capillaries. These lymphatic capillaries pick up this fluid that your blood leaves behind. This is the source of lymph. Once that fluid is picked up by a lymphatic capillary, it is now lymph. The lymphatic system cleans and filters this fluid, then returns it to your blood. The lymphatic all flows up towards your shoulders, it connects to your subclavian veins, and the fluid is returned to the blood. This is our next chapter, so we'll get to learn more about the lymphatic system in chapter 21. You already know from the study of blood that you have 5 liters of blood in the human body. You learned in this chapter that you have 60,000 miles of capillaries in your body. To give you a comparison, the United States from coast to coast is just over 2,000 miles. So if you laid all your capillaries out end to end, they could go back and forth across the country about 30 times. That is a lot of capillaries. You don't have enough blood to fill all of your capillaries at the same time. So you have local blood flow. Local blood flow is how you distribute this blood through your body. Your goal is to achieve adequate perfusion. This means that you meet the needs of each tissue in your body. There are 3 things that determine how much blood goes to each tissue. So now we can look at these 3 factors. The first one is degree of vascularization. This is how many blood vessels are in a tissue. The top picture shows low vascularization. As you can see, there aren't very many blood vessels, not very many capillaries in this tissue. So this tissue would have low blood flow. These would be tissues that have low metabolism. Since they have low metabolism, they don't need very much blood flow. Examples of this would be your tendons and ligaments. If you've ever had a sprain, you probably know that those take a very long time to heal. A damaged tendon or ligament can take about 6 months to heal. The reason for the slow healing is this low degree of vascularization. The blood supply to tendons and ligaments is so low that it takes them several months to heal. The bottom picture shows a high degree of vascularization. This would be to tissues that have a high metabolism. So this is high blood flow for high metabolism tissues. Examples of this would be like your brain, your heart, your skeletal muscles. Your body is always adapting. You can change your degree of vascularization. Okay, let's suppose that you have been sedentary and you suddenly start exercising. You would add more blood vessels to that tissue. Or if you've been exercising and then you become sedentary, you would lose blood vessels to your skeletal muscle tissues. Another factor that can cause change is cancer. So we know that it can change based on your activity level. Cancer can also change. New cancer tumors cause angiogenesis. Angiogenesis means you're forming new vessels so that you are increasing the degree of vascularization. So somebody gets cancer and they have a tumor. That tumor needs a lot of blood flow. It needs oxygen and nutrients. So the tumor will induce angiogenesis. It will force your body to grow new vessels to feed it. One of the research areas in treating cancer is to try and stop this angiogenesis. If you can stop that, you could starve the tumor. Okay, another factor is local control. Capillary beds can open and close. The top picture, you can see that the capillary bed is open. And in the bottom picture, you can see that the capillary bed is closed. There are muscles. Notice these little muscles here? Those are muscles that can open or close the capillary bed. These muscles are triggered by the amount of waste. So think about this. Cells have metabolism. And through their metabolism, they produce waste. Okay, the higher the metabolism, the more waste. As the waste builds up, it stimulates those muscles to open the capillary bed. Then blood flows through, cleans out the waste. Now the waste level is low, and so the muscles close the capillary bed. This way, you're always getting just the amount of blood to a tissue that it needs. When a tissue is resting, doesn't make very much waste. So it's going to have a low blood flow. When a tissue is active, it will make more waste. And now that waste will stimulate these capillary beds to open more often, and you will have high blood flow. So this is how you adjust blood flow to always meet the needs of that particular tissue. Our third factor is total blood flow. Think of this like the cardiac output that you already learned. This is the amount of blood that the heart is pumping. The more blood that the heart pumps, the more blood each tissue receives. Think of it like pizza. If I said I was going to give you a pizza and you were to get 25% of that pizza, if I bring in a large versus a small, you'll get more. The bigger the pizza, the more you will get. It's the same idea with blood flow. The faster and harder the heart is pumping, the more blood is sent to the entire body. Let's look at blood pressure. This is measured using a sphygmomanometer and a stethoscope. The idea is that you collapse an artery, then you let it refill, and you see how much pressure it takes to reopen that artery. Blood pressure is measured in millimeters of mercury. So you'll notice it says mmHg. That stands for millimeters of mercury. If you have a tube, and at the bottom of the tube, you have a bulb, and you put mercury in this bulb. When you squeeze the bulb, that causes the mercury to move up into the tube. You then get a ruler, and you place your ruler next to the tube, and you see how many millimeters the mercury has moved up. That's how you get your units of measure for blood pressure. The sphygmomanometer is the cuff that goes around the person's arm. This cuff is inflated. As you inflate the cuff, you squeeze the artery and collapse it. Here you can see the collapsed artery. Then you slowly release the pressure. There's a tube that goes from the cuff to your dial. Here's your dial. This dial is telling you your millimeters of mercury. As you release the pressure, the mercury starts falling back down. Your artery is also going to open back up. The pressure in the artery is the greatest during systole, when the heart contracts. So as you release the pressure, at some point, the pressure of the heart pumping is great enough to overcome the pressure of the cuff squeezing. At this point, the artery will reopen and blood enters it. When the blood re-enters the artery, it makes a sound. It's a gurgling sound that you can hear. When you hear that sound, you look at your dial. You see how high the mercury is on your dial at that time. That tells you the pressure in the cuff when the artery reopens. This is your systolic pressure. In an average healthy adult, this would be around 120. Then you continue to release the pressure. You can see here when the blood first re-enters, it's kind of gurgled. It's a turbulent blood flow. As you release pressure, the artery opens all the way. Okay, here you can see the artery fully open. Once the artery is fully open, the blood flow is smooth. You can see you don't have those swirly lines there anymore. It's just nice, smooth blood flow. So the sound you hear from your stethoscope changes once this blood flow smooths out. When you hear that change in sound, you again look at your mercury dial and you see how high up the mercury is. This corresponds to diastole in the heart when the heart is resting. So this is your diastolic pressure. Which in your average healthy adult is about 80. That's how you measure blood pressure. Once you have blood pressure measured, there are a couple of calculations we can make from it. For these calculations, we're going to assume that we have an average healthy adult at rest with a blood pressure of 120 over 80. The first measurement, or the first calculation that we want to take from this is pulse pressure. This picture shows an artery when it's in systole and when it's in diastole. This top picture shows the systole. This is when the ventricles contract and push blood into the arteries. The arteries have to expand to accept this pulse of blood from the heart. The bottom picture shows diastole, when the heart is relaxed and refilling with blood between beats. During diastole, the artery rebounds. It recoils back to its original. Pulse pressure is the difference between these. It's how much change you have during systole. To calculate pulse pressure, you simply subtract. You take your 120 minus 80. And in this case, it's 40. So a typical pulse pressure is about 40. This indicates how well your arteries expand. Healthy arteries are elastic. So they can expand to receive that pulse of blood from the heart. If arteries are hardened, then they won't expand to receive that pulse of blood. So knowing someone's pulse pressure gives you an idea of the elasticity and health of their arteries. The other calculation that we want to look at is mean arterial pressure, which is abbreviated MAP. Think back to math classes you've had. Mean means average. So MAP is the average pressure in your arteries. Okay, think about what you learned about the cardiac cycle. You have the entire heart in diastole. This is when the heart relaxes to refill. Then you have atrial systole. During this time, the atria contract while the ventricles remain relaxed. Then you have ventricular systole. The ventricles contract. This is when you push that pulse of blood into the arteries. During these two steps, diastole and atrial systole, you have your diastolic pressure. Which would be our 80. During this time, you have your systolic pressure. Which would be our 120. So only 1/3 of the time you're in systolic pressure. So the formula for calculating MAP has to take into account that you only spend 1/3 of your time in systolic pressure. You also don't want to count systolic pressure twice. So to find the MAP, you take your diastolic pressure and you add 1/3 of your pulse pressure. Okay, the 1/3 is because you only spend 1/3 of the time in systolic, and the reason you're using pulse pressure is because that's the increase that you get during systolic. So if we have a typical person with a blood pressure of 120/80, MAP would be 80, the diastolic, plus 1/3 of 40. That's your pulse pressure. This works out to 93. So 93 is a typical mean arterial pressure. MAP is important because it indicates perfusion. As long as you have a good healthy MAP number, you know that you are getting enough blood to your tissues to meet their needs. As long as your MAP is between 70 and 110, you will have adequate perfusion to your tissues. A MAP that is too low indicates that you are not getting enough blood to your tissues. So it indicates poor perfusion. This means that you will not pick up waste, so your cells will be building up in their own waste. It means you're not getting enough oxygen and nutrients to your cells. And it means that your kidneys can't adequately filter your blood and your blood will start to become toxic. Because you rely on an adequate MAP in order to push blood through the kidneys. If MAP is too high, you can also get problems. This means that the pressure in your capillaries is too high. So remember from an earlier lesson that the pressure, the hydrostatic pressure in capillaries should be about 35. If your MAP is higher, then you will have higher pressure in your capillaries. This means you will push more water out of your blood. This will give you edema. You'll be pushing too much water out of your blood and it will collect in your tissues. We've talked about blood pressure, which is the force of the heart pushing blood through the arteries. By the time the blood flows through the arteries, then through the capillaries, and gets into the veins, pressure is very low. Also, veins do not have a pulse. So when it comes to blood flow in the veins, the heart really isn't doing much. You do not have enough pressure from the heart to push blood through the veins. So you have to rely on other methods to help get the blood through your veins back to your heart. So we have two methods we're going to look at here. One of these methods is the skeletal muscle pump. You can see here are your muscles. And when your muscles are active, they squeeze a vein. So in this picture, you can see a vein being squeezed between two muscles. It's kind of like squeezing a tube of toothpaste. When the muscles squeeze the veins, they force that blood to move. Notice also that the veins have valves. These valves are similar to the semilunar valves in the heart. They only open upward or toward the heart. They won't open the other direction. So when the muscles squeeze the veins, this pushes the blood, and the valves will only open toward the heart. So the blood has to move this direction. It can move up through the open valves. It can't move back down because the valves won't open that way. The other method that we have is the respiratory pump. This is from your breathing. Here is the diaphragm. You can see it in both pictures. And here in the teal, you can see the chest cavity. Okay, the picture on the left, she is inhaling. And in the picture on the right, she is exhaling. Okay, so look at the differences. When you inhale, two things happen. The diaphragm goes down. Okay, you can see on the left that the diaphragm is lower and it's flat. On the right, it's domed up and it's higher. The diaphragm going down like that pushes on your abdomen. And it has the effect of squeezing the veins. This puts pressure on the veins and squeezes them. So it's similar to the skeletal muscle pump. You're squeezing the veins. The other thing that happens with the respiratory pump is the size of the chest cavity. If you compare the size of the chest cavity here during inhaling to here during exhaling, it's bigger when you inhale. If a cavity is bigger, it creates suction. Kind of like when you drink through a straw, you're creating suction. Every time your chest cavity is bigger during inhaling, you create suction. This suction helps to pull blood to the heart. So you're moving blood through your veins because out in your body you have skeletal muscles squeezing those veins, pushing the blood back toward the heart through the one-way valves. In your torso, you have your diaphragm going down every time you exhale, squeezing your abdomen, pushing that blood through the veins, and you have your chest getting bigger, which creates suction and pulls that blood into the heart. This goes along with your activity level. Think about what you learned back in chapter 19 with increased venous return. When you are active, your muscles are working more. And you breathe deeper. This means that your skeletal muscle pump and your respiratory pump are going to send more blood to your heart. This means you have an increased venous return. You're putting more blood into the heart while it's in diastole and refilling. So think about what you learned in the last chapter. An increased venous return gives for an increased cardiac output. You also, because of the increased venous return, stretch the heart. And when you stretch the heart, you activate that Frank-Starling law, which means the heart's going to contract with more force. Just like when you pull the rubber band and you let it go, it springs back with more force. So now, because of the increased venous return and the Frank-Starling law, you increase your cardiac output. So you already know that when you're active, your heart is beating faster and harder. You have higher cardiac output when you're active. This just shows how those go along. We're tying these ideas together. When you're active, these two pumps work more and help to increase that cardiac output. Okay, now we can look at some problems that you can get in your veins. First, let's look at a nice healthy vein. So on the left here, you have a healthy vein. Okay, you can see that the blood flows up, the valves open here, and they let the blood flow up. Then the valves close behind the blood, and the blood can't go back down. Okay, now let's compare that to the diseased vein on the right. In this vein, notice that it is wider. See how the healthy vein is nice and narrow? The diseased vein is very wide. This typically happens in your legs. This is a varicose vein. You typically get varicose veins in your legs. So let's think about what's happening there. Sometimes people tend to cross their legs. Or you might sit in a chair with your legs pressed against the edge of the chair. Some people have jobs where they have to stand for long periods of time. Okay, any of these things are going to cause blood to build up in your veins. If you're crossing your legs or pressing your legs against the edge of a chair, you're physically collapsing that vein so that blood can't get through. If you're standing for a long time, then gravity is keeping blood down in the legs. Now, if you're standing and moving around, you're going to be fine because the skeletal muscle pump is going to work and push that blood up. But if you're just standing still, the skeletal muscle pump is not going to push the blood. Gravity is going to keep the blood there. So the result of these things is that you get blood buildup in your leg veins. This stretches your veins out. Okay, now look at the valve. The two flaps of the valve are too far apart that they don't meet. Notice a closed valve, the two flaps kind of hold each other up. If the vein is stretched out, the two flaps don't meet and they can't hold each other up. So now the valve can't close. You can't keep blood moving toward the heart. So now, because you've stretched out the vein, blood builds up even more. And this is how you get varicose veins. So there's a lot of factors that go into it, genetics and weight and other things, but you do have some control. If you want to avoid varicose veins, you can make sure that you don't stand still for long periods of time. You can wear compression socks. Those help support your veins. And you can make sure you don't cross your legs or sit with your leg pressed against the edge of a chair. Another problem that you can get is a deep vein thrombosis. So this is when you get a blood clot that you don't want. So in this case, we are dealing with a blood clot. That's what a thrombosis is. Okay, this tends to happen if you are inactive. Okay, such as recovering from surgery, or if you're traveling and so you're sitting in a car, sitting in an airplane for a long period of time. When you're inactive, your skeletal muscle pump and respiratory pumps are not doing much. So you tend to get a lack of blood flow in the veins. The blood can actually become stagnant in the veins. And this is especially true in the legs. This typically happens in the legs. Okay, being dehydrated is another problem. If you are dehydrated, you don't have enough water in your blood, so the blood is going to be thick. So, being inactive and having dehydrated, thick blood increases the chances that your platelets will start to clump together. And if this happens, you can form a clot in your vein. Okay, this can then lead to another problem of an embolus. So you can see here where it says embolus. Here's your clot in your vein. Here's an embolus. An embolus is when all or part of that clot breaks free. Okay, this can then cause other problems. If we look here at this picture that gives us an overall of the blood flow in the body, a deep vein thrombosis will typically form about here in a leg vein. Okay, then if that clot forms and becomes an embolus, so it's flowing, well, it's in a vein, so it's going to flow back toward the heart. If you think about the systemic veins, they start off really small. So a systemic vein that's out in your body is going to be small, narrow. As veins get closer to the heart, they merge together to make bigger veins. So as you get closer to the heart, the diameter gets wider. So now you can see here, it's very wide as we get close to the heart. The embolus can't be any bigger than the vein it formed in. So the embolus is going to have a maximum size of the vein it formed in. Which is typically going to be more narrow. So now, as we get here to the heart, you have this embolus. It has plenty of room to move, so it's not going to get stuck. Think about your path of blood. We're going to go into the right atrium. The chambers of the heart are definitely bigger than your veins. So again, the embolus has plenty of room. It's probably not going to get stuck. It's going to go into the right ventricle, which will then pump it into the pulmonary trunk. And from the pulmonary trunk, it's going to go into the pulmonary artery. Now the vein is in a pulmonary artery heading toward the lungs. Now the embolus is in a pulmonary artery heading toward the lungs. So it will move through the veins and the heart, and then it will be pumped into the pulmonary trunk, to the pulmonary artery. Okay, arteries branch out as you move away from the heart. Here you can see the pulmonary artery branching out. And as they branch, they get smaller. So as this embolus is moving into the lungs, it gets into these smaller arteries, and now it's going to find a place where it gets stuck. This is now a pulmonary embolism. And this is very dangerous because it can block blood flow through the lungs. So you start off with a clot forming in your leg because you're inactive, you're dehydrated, you might be traveling or recovering from surgery. All or part of that clot breaks loose. It becomes an embolus. The embolus travels through your veins, which get wider as they go to the heart. It travels through the heart. Then it travels through a pulmonary artery out to the lungs. Now the artery is branching and getting smaller. It gets stuck in one of those arteries of the lungs and blocks the blood flow. Now we can look at a video that was taken in an operating room of some surgeons removing a pulmonary embolus.
This is a case of an acute pulmonary embolism from a deep vein thrombosis. Here we're performing a pulmonary thromboembolectomy. Here we've established the patient on cardiopulmonary bypass. A arterial line is placed in the right superior pulmonary vein as seen here. This is wide off of the arterial cannula and clamp. As you can see, the clamp is in place. We are on full cardiopulmonary bypass support. The next step is to apply the aortic cross clamp and achieve cardiac arrest. Here we're performing the pulmonary arteriotomy with a knife and then scissors, and you can already get a glimpse of the thrombus inside the main pulmonary artery. As it branches, you can see a grasper is used to remove the thrombus. This is a very large saddle embolus that originated likely from the patient's femoral and iliac vein. She had a fracture of her right lower extremity, was in a cast, and this was a likely source from the right leg. You can see the embolus is removed. A Fogarty catheter is used to clear any further clots, which none are found. Then at this point in time, we take the clamp off of the right superior pulmonary vein cannula. This allows us to perform retrograde pulmonary perfusion. Goes from the pulmonary veins back through the lungs and out the pulmonary artery, as you can see here. Small emboli and air are cleared. You can see in this portion of the video. Once we're satisfied that the pulmonary arteries have been cleared of debris, and we ventilate as well during this process, once we're satisfied with that, we'll stop the retrograde pulmonary vein perfusion. We'll inspect with the thoracoscope. You can see here the small branches of the pulmonary veins are cleared. The main trunk of the pulmonary artery is also clear. And we inspect the thrombus one more time. You can see this is a very well-formed thrombus that is soft. And that ends the case. The patient has done very well following the surgery, and we anticipate a full recovery.
So we know that the heart pumps and pushes blood into arteries. But arteries resist receiving this blood. So the heart has to work to overcome this resistance. The more the arteries resist, the harder your heart has to work. There are 3 factors that determine how hard your heart has to work to pump the blood into your arteries. So these 3 factors determine the resistance of your arteries. The first factor is artery diameter. Okay, here we have a constricted artery. And here we have a dilated artery. The constricted artery has more resistance. Right? Think of like a hose or a straw. If something is narrow, it's harder to push fluid through that. The dilated artery has less resistance. So if your arteries are wide, it's a lot easier for the heart to pump that blood through those nice wide arteries. Okay, then let's look at what causes arteries to constrict or dilate. This is controlled by your autonomic nervous system. So you remember this from chapter 15. This is where we have sympathetic and parasympathetic. Now remember that sympathetic is the only one that controls arteries. Parasympathetic has no effect on the diameter of your arteries. Okay, when you have increased sympathetic, that is going to give you overall constriction. Now, sympathetic stimulation will dilate the blood vessels in your skeletal muscles, but it causes constriction of all other blood vessels. The net result is that you have more constriction than dilation. So when you increase your sympathetic stimulation, you get a net effect of constricted blood vessels, and your heart has to work harder to pump the blood. This also increases your blood pressure. Now remember, there's no parasympathetic. So in order to dilate blood vessels, all you do is turn down your sympathetic. If you have less sympathetic stimulation, then the blood vessels will dilate. When they dilate, this decreases your blood pressure and your heart doesn't have to work quite so hard. Our next factor is vessel length. Okay, blood vessels have friction in them. So as blood flows through the blood vessel, you get friction. The longer the vessel is, the more friction you have. So the top one here, the shorter vessel, would have less friction. So this would be less resistance. The bottom one, the longer vessel, would have more friction. So this would be more resistance. So one of the big factors that determines your blood pressure is the total length of blood vessels in your body. We're not talking about one individual vessel. We want to know the total vessel length in your body. Okay, the more total vessel length you have, that means you have more resistance, which means that your heart has to work harder and you have higher blood pressure. This is why there's a relationship between weight and blood pressure. Obesity and blood pressure often go together. If you are obese, you have a lot of adipose tissue. All that adipose tissue has blood vessels to it. Having lots of adipose tissue means you have a lot more total blood vessel length. And the more total blood vessel length you have, the higher your resistance and higher your blood pressure. This is why losing weight can often reduce blood pressure. Because if you lose weight, then you lose that adipose and you lose those blood vessels that were in the adipose. So by losing those vessels, you reduce your vessel length. And reducing vessel length will reduce your resistance. Our third factor is your blood viscosity. Okay, remember from chapter 18 that there's a direct relationship between viscosity and hematocrit. Remember in lab when you made the 40% and 60% hematocrit and raced them down the paper? So the higher your hematocrit, means you have a higher viscosity. And you also learned in chapter 18 with the dangers of blood doping, that makes your blood too thick and it's hard for your heart to pump. So higher viscosity means that you have more resistance. So the thicker your blood is, the more resistance you have, the harder it is for your heart to pump, and your blood pressure goes up. So these are the factors that determine how much your heart has to work to pump blood through your arteries, which then in turn affects your blood pressure. The more resistance you have, the higher your blood pressure is. The rest of our chapter focuses on blood pressure. So let's take some time to look at all the factors that affect blood pressure. Your blood pressure is a result of three main things. The first is cardiac output. We learned about this in chapter 19. This is the liters of blood pumped by one ventricle in 1 minute. Our second factor is resistance. We learned about this in an earlier video in this chapter. Arteries resist receiving blood from the heart. And the heart must work to overcome this resistance. Our third factor is blood volume. This is basically the amount of water in your blood. Each of these factors is further broken down into things that influence them. We already know from chapter 19 that cardiac output is heart rate times stroke volume. Resistance has three factors. The first is vessel diameter. The second is vessel length. And the third is blood viscosity. The amount of water in your blood is controlled by two things. One is how much you drink. The other is how much urine your kidneys produce. Each of these individual factors can act to raise or lower blood pressure. Your total blood pressure is the combination of all of these factors working together. We know with heart rate, if you increase heart rate, you increase cardiac output. A higher cardiac output will result in higher blood pressure. Things that increase heart rate include sympathetic stimulation and positive chronotropic agents. This would be things such as thyroid hormone, caffeine, nicotine, and cocaine. You can also decrease heart rate. If you decrease heart rate, you decrease cardiac output, which decreases blood pressure. Parasympathetic stimulation will decrease heart rate, as will negative chronotropic agents. This would include things such as beta blocker and calcium channel blocker drugs. Stroke volume can also have an effect. If you increase stroke volume, you increase cardiac output, which increases blood pressure. Stroke volume is increased by sympathetic stimulation, increased venous return, the Frank-Starling law of the heart, and positive inotropic agents. This would include your same positive chronotropic agents along with digitalis. This is also known by its brand name, digoxin. This is the drug that traps the calcium in the muscle and makes it contract harder. If you decrease stroke volume, you will decrease cardiac output, which will decrease blood pressure. We're not going to put parasympathetic here. Remember, it only affects the nodes, not the myocardium. But this could be negative inotropic agents and electrolyte imbalance. Now we can look at the resistance factors. With vessel diameter, if you constrict your blood vessels, you increase resistance, which increases blood pressure. If you dilate your vessels, you decrease resistance, which decreases blood pressure. When it comes to vessel length, longer vessels will increase resistance, which will increase blood pressure. Having shorter vessels, such as by losing weight, will decrease resistance, which will decrease blood pressure. And with viscosity, having high viscosity will increase resistance and increase blood pressure. A lower viscosity will decrease resistance and decrease blood pressure. Now we can look at blood volume. The more you drink, the more your blood volume. The more blood volume you have, the more pressure it puts on your vessels. So you have higher blood pressure. When it comes to urine production, the more urine you make, the lower your blood volume, because making urine takes water out of your blood. And if you reduce blood volume, you reduce blood pressure. So drinking more raises blood pressure, urinating more lowers blood pressure. In the next videos, we'll look at how your body manages these factors in order to maintain homeostasis of your blood pressure. Maintaining homeostasis of blood pressure is very important. On average, it's about 120/80. This does vary from person to person. Everyone has their own normal. It is important to keep blood pressure at homeostasis. As you know from your study of MAP, if it is too low, then you do not get adequate perfusion to your tissues. And you can't push the blood through your kidneys to filter it. If pressure is too high, then you will damage your blood vessels and damage your kidneys. So your body has two main systems to maintain homeostasis of blood pressure. You have nervous control. Nervous control is your medulla oblongata. So this is part of the brain, and it uses the autonomic nervous system. Your medulla oblongata has to monitor what's going on with your blood pressure. So it receives information from those same receptors that we learned about in chapter 19. You have the baroreceptors that detect stretch, and the chemoreceptors that detect carbon dioxide, pH, and oxygen of the blood. These receptors report to the medulla oblongata, then it decides if it wants to use sympathetic or parasympathetic. If the medulla oblongata decides to use sympathetic, you will increase your heart rate, increase your stroke volume, and have vasoconstriction. These factors will all increase blood pressure. If the medulla oblongata decides to go with parasympathetic, you will decrease heart rate, which will decrease blood pressure. You also have hormones that help with the regulation of blood pressure. Your kidney is in charge of one of these systems. As your kidney filters blood, it monitors blood pressure. Your kidney will also respond to sympathetic stimulation about blood pressure. The kidney is in charge of a system called the renin-angiotensin system. So if the kidney detects that blood pressure is low, or the kidney receives sympathetic stimulation, it will activate the renin-angiotensin system. This is a group of hormones that will then act to raise blood pressure. They will increase blood pressure by causing thirst so that you drink more and increase your blood volume, by reducing urine production, so that you retain water in your blood and increase blood volume, and by stimulating vasoconstriction. Okay, the heart is in charge of the other hormone. If blood pressure is too high, it stretches the heart. When the heart is overstretched by high blood pressure, it will secrete atrial natriuretic peptide, which we can abbreviate ANP. This hormone will reduce blood pressure, and it does so by increasing urine production, by causing vasodilation, and by inhibiting the renin-angiotensin system. The next couple of videos will give more detail of how you use nervous and hormone to regulate blood pressure. This video is just an introduction and overview. Now we can look at nervous regulation of blood pressure. This begins with the medulla oblongata receiving information. You have here the central chemoreceptor. It receives information about pH of the cerebral spinal fluid. Then you have in your carotids and your aortic arch your peripheral chemoreceptors. They provide information about pH and carbon dioxide of the blood. You also have the peripheral baroreceptors. Which tell you how much these arteries stretch. All of this information is used by the medulla oblongata to decide how it should regulate blood pressure. Let's take a minute to review the relationship between carbon dioxide and pH. You first learned about this back in Chapter 3 with cellular respiration. We know that carbon dioxide forms acid in your blood. So if you have high carbon dioxide, you will have more acid, which means your pH will be low. If your carbon dioxide is low, you lack acid in the blood, which means your pH will be too high. Remember that you rely on your lungs to correct these problems. So the more you exhale, that means you're losing acid and you raise pH. The less carbon dioxide you exhale means you allow carbon dioxide to build up in the blood, therefore acid builds up in the blood, and you reduce pH. These relationships between carbon dioxide and pH are important for understanding regulation of blood pressure. Now let's see your two options of what can happen. You have sympathetic and parasympathetic. On this side, we will do sympathetic. Okay. If your pH is too low, this means you have high carbon dioxide in your blood. That means you need to pump more blood through your lungs, get rid of the carbon dioxide, and bring your pH back up. So you will use sympathetic stimulation to do this. You have two centers for sympathetic stimulation. You have the cardioacceleratory center. It will send sympathetic stimulation to the heart. And you will have norepinephrine onto the heart. This will affect your nodes by having them increase your heart rate. It will affect your myocardium by having it increase your stroke volume. By doing both of these things, you increase cardiac output, which increases blood pressure. Then you also have the vasomotor center. This controls your blood vessels. This center will stimulate vasoconstriction. Vasoconstriction will increase resistance, and increasing resistance will increase blood pressure. So here you have three things that happen with sympathetic to increase blood pressure. You increase heart rate, you increase stroke volume, and you have vasoconstriction. This way you send more blood through the lungs and you get rid of that carbon dioxide to fix your pH. Okay, on the other hand, you have parasympathetic. If your pH is too high, which would be because your carbon dioxide is too low, then you want to send less blood through the lungs. That way you can allow carbon dioxide to build up in the blood and bring your pH back down. So in this case, your medulla oblongata will use the cardioinhibitory center. This will stimulate the vagus nerve to secrete acetylcholine onto the nodes of the heart. This will decrease your heart rate. And if you decrease heart rate, you decrease cardiac output, which decreases blood pressure. So this is your nervous regulation of blood pressure. It's the medulla oblongata using sympathetic and parasympathetic stimulation to alter cardiac output and resistance in the blood vessels. Now we can look at how you use hormones to regulate blood pressure. We will start with the renin-angiotensin system. This is a group of hormones that act to raise blood pressure. We will begin with the liver. The liver makes angiotensinogen and secretes it into the blood. So your liver keeps a supply of angiotensinogen in your blood. Okay, angiotensinogen is an inactive hormone. So it's not doing anything. I think of it like a can of SpaghettiOs. It's just sitting there in your cabinet in case you need it. That's how angiotensinogen is. Then we have the kidney. Your kidney filters your blood. As it does so, it's monitoring your blood pressure. It will respond to a drop in blood pressure. Your kidney also responds to norepinephrine, sympathetic stimulation. So if your kidney detects that blood pressure is going down, or your kidney gets sympathetic stimulation, it secretes renin. Renin is an enzyme, and it converts angiotensinogen to angiotensin 1. So now when you have this renin enzyme in your blood, the renin and the angiotensinogen mix together in your blood, and you get angiotensin 1. Next, we go to the lungs. Your lungs contain an enzyme. It's called ACE for short. It stands for angiotensin converting enzyme. Now you have angiotensin 1 flowing in your blood. Your blood flows through your lungs. And as it does, the angiotensin converting enzyme in your lungs converts it to angiotensin 2. Angiotensin 2 is your active hormone. Remember when I said that angiotensinogen is like SpaghettiOs? It's inactive. It's there in case you need it. Renin is like the can opener that you use to open your can of SpaghettiOs. Then the ACE in the lungs is like the microwave. You warm up your SpaghettiOs. Angiotensin II is your lunch that's ready to eat. This is your active hormone. This hormone has synergistic partners. So think back to chapter 17. You learned about hormones that can work together as synergistic partners. So the next thing that angiotensin II is going to do is get its partners. Angiotensin II goes to the hypothalamus, and it stimulates the hypothalamus, which then stimulates the posterior pituitary, which secretes ADH, which is antidiuretic hormone. It also goes to the adrenal cortex. Remember, the adrenal glands are the two little glands that sit on top of the kidneys. The medulla is the inner part, the cortex is the outer part. Angiotensin II stimulates that outer cortex. It then secretes aldosterone. ADH and aldosterone are the two synergistic partners of angiotensin II. So over here, we can put that angiotensin II will go stimulate the hypothalamus, which then stimulates the posterior pituitary, which secretes ADH, or antidiuretic hormone. Angiotensin II also stimulates the adrenal cortex, which secretes aldosterone. So now you have a set of 3 hormones: ADH, aldosterone, and angiotensin II. These 3 hormones are going to work together to raise blood pressure. Okay, now we can look at the effectors and see what they do to raise blood pressure. This row represents our effectors. These are the body parts that are going to respond to the hormones and do the actual work of raising the blood pressure. The first one is the hypothalamus. This is where you control thirst. These hormones stimulate the hypothalamus to make you feel thirsty. If you feel thirsty, you will drink. And when you drink, you increase your blood volume. And if you refer back to that chart we made before, you'll see that when you increase blood volume, you increase blood pressure. The next effector is your blood vessels. These hormones cause vasoconstriction. So they're going to make the blood vessels get more narrow. When you do that, you increase resistance. And increasing resistance increases blood pressure. Our third effector is the kidney. These hormones tell the kidney to make less urine. If they make less urine, that means more blood is left, more water is left in the blood. So by leaving more water in the blood, you increase blood volume, which increases blood pressure. So here is the renin-angiotensin system. This is the group of 3 hormones that act to raise blood pressure. You do this when blood pressure is low or when you have norepinephrine. Next, we can look at AMP. This hormone is secreted by the heart. So this begins if blood pressure is too high. High blood pressure will overstretch your heart. When your heart is being overstretched, your right atrium secretes AMP, which is atrial natriuretic peptide. This is a hormone that acts to lower blood pressure. It has 2 effectors. The first effector is the kidney. AMP will stimulate the kidney to make more urine. This will remove water from the blood. So you reduce blood volume, which reduces blood pressure. The second effector is your blood vessels. AMP causes the blood vessels to vasodilate. This reduces resistance, which reduces blood pressure. A third thing that AMP does is it inhibits the renin-angiotensin system. So it is both actively reducing blood pressure through its effects on the kidneys and blood vessels, and it's preventing another system that would counteract this and raise blood pressure. So here is AMP, the one hormone that lowers blood pressure. Let's make a chart to summarize how you regulate blood pressure. We know that you have 2 basic methods, nervous and hormone. Nervous regulation is by the medulla oblongata. It controls the 2 divisions of your autonomic nervous system. So we have sympathetic, and we have parasympathetic. Parasympathetic uses the cardioinhibitory center. This center uses the vagus nerve to secrete acetylcholine onto the nodes of the heart. This reduces heart rate, and if you reduce heart rate, you reduce cardiac output, which reduces blood pressure. Your sympathetic system has two centers. It has the cardioacceleratory center and it has the vasomotor center. The cardioacceleratory center sends norepinephrine to two parts of the heart, the nodes and the myocardium. When you put norepinephrine on the nodes, you increase heart rate. This increases cardiac output, which increases blood pressure. When you put norepinephrine on the myocardium, you increase stroke volume, which increases cardiac output, which increases blood pressure. The vasomotor center is what controls your blood vessels. Sympathetic stimulation from the vasomotor center causes vasoconstriction. This increases resistance, which increases blood pressure. So there is your nervous regulation through parasympathetic and sympathetic. With hormone, we also have two different options. We have the renin-angiotensin system. This is three hormones: angiotensin II, ADH, and aldosterone. These hormones have two main effects. They increase your blood volume by causing the hypothalamus to feel thirsty and by causing the kidneys to make less urine. And if you increase blood volume, you increase blood pressure. They also act on your blood vessels and cause vasoconstriction. This increases resistance, which increases blood pressure. Our other hormone is atrial natriuretic peptide, or ANP. This hormone reduces blood pressure. It acts on the kidney to make more urine. This reduces blood volume, which reduces blood pressure. It also acts on the blood vessels to cause vasodilation. This reduces resistance, which reduces blood pressure. ANP, remember, also inhibits the renin-angiotensin system. You have a connection between nervous and hormone because the sympathetic system can send norepinephrine to stimulate the kidney to secrete renin and get the renin-angiotensin system started. So the renin-angiotensin system can be its own thing if the kidney is responding to a decrease in blood pressure. It can also be stimulated by sympathetic and inhibited by AMP. So here is a summary of the ways that your body regulates your blood pressure.